going to present a short video today trying to answer some of the questions that people ask me, in particular with relation to premium lens use when they undergo either cataract or refractive lens exchange. We've been very fortunate over the last few years that there have been huge advances in surgical techniques which allow us to much more accurately predict post-operative refractive status and therefore have much greater confidence in decreasing patients' needs for glasses or contact lenses after their cataract or refractive lens exchange procedure. The difference between cataract surgery and refractive lens exchange really revolves around the reason why the surgery is being done. In patients under 50 with a clear lens, the procedure is referred to as refractive lens exchange, the main aim being to reduce patients' need for spectacles. Once we start to head over 50, certainly over 55, and introduce some lens opacity, some blurring of vision due to cataract, procedure is referred to as cataract surgery. Increasingly these days, surgeons refer to cataract surgery using premium lenses as refractive cataract surgery, allowing not only removal of the cataract itself and improved vision, but also decreased need for spectacles. The procedures themselves are identical, i.e. cataract surgery and refractive lens exchange both take place through small corneal incisions, approximately 2 millimeters wide. Both use what is generally considered the gold standard removal of lens, which is ultrasound technique or phacoemulsification, and both require insertion of an intraocular lens for focusing after removal of the natural lens. Incisions are placed through the cornea, approximately 2 millimeters wide. The lens is accessed and removed via an ultrasound probe, and then the replacement lens is inserted through the same small incision. The first aspect of refraction that we deal with is how long or short-sighted to leave people. The vast majority of patients, of course, would prefer to have no glasses for distance, and we have much greater confidence in the formula that we use now, predicting lens powers, to enable us to achieve that in around 95% of patients. A few patients who have been short-sighted all their lives quite like not having to wear glasses for near, don't mind wearing glasses for distance, and just occasionally we will leave patients short-sighted. Few patients present having been short-sighted in one eye or having made themselves short-sighted in one eye by use of contact lenses preoperatively. They're quite used to this concept called monovision, i.e. one eye set for distance and one eye set for near, and we can replicate this with surgery pretty accurately. And in those patients who are used to monovision, then that's also an option to try and reduce spectacle use post-operatively. Next thing we turn our attention to is the degree of astigmatism. If we look at the cornea, ideally it would be perfectly round in all dimensions. This is rarely the case. Some degree of natural astigmatism is normal and actually helps with depth of focus. It's impossible to accurately measure or subsequently treat astigmatism to entirely remove it, but we are now reasonably confident at reducing astigmatism to below 1 diopter in most surgical procedures. We can do this either through incision placement, whereby making an incision on the steep axis of the cornea relaxes it, makes it rounder and a better refracting surface, or if the astigmatism is more than 1, procedure of choice now tends to be a toric intraocular lens. So far we've covered good prediction of glasses power, we've treated astigmatism, but of course what people also want is the ability to see not only for distance but for near as well without using spectacles. So-called multifocal lenses all affect the quality of the image produced on the retina. This is basic laws of physics. If one splits up the light rays into a near and distance portion, the intensity of the light falling on the retina is decreased, and inevitably there will be a loss of image quality. The vast majority of patients, if chosen carefully with no other eye disease, won't actually notice this drop in quality of image. But patient selection is key, and it is certainly the case that by no means is everyone suitable for a multifocal lens. Multifocal lenses work in slightly different ways, but the basic principle of most of the models on the market is that they have concentric rings cut onto the surface of the lens, providing a distance, an intermediate, and a near focus. The problem is that each of these rings has the potential to cause scatter of light and a halo effect, usually particularly noticed when driving at night. Therefore, multifocal lenses are not suitable for patients who do a lot of night driving or pilots, for example. The more one tries to do with the lens, the more the light is broken up, the higher the risk of halos and side effects, and the greater the chance of an unhappy patient. For the vast majority of my patients, I now avoid the stronger multifocal lenses, i.e. those that allow patients to see in the distance and for very near small print. I feel it's too big an ask of the lens. It increases the risk of side effects, and the majority of patients simply want a bit of help with intermediate computer type distance, dashboard type distance, and are quite prepared to put on a pair of reading glasses occasionally for small print, particularly in dim light. The benefit being avoiding some of the side effects associated with the stronger multifocal lenses. These distance and intermediate focusing lenses are often called extended depth of focus lenses, or EDFs. The extended depth of focus lenses have a better safety profile in terms of avoiding side effects such as glare and halo. They interfere less with the image quality, and they are more tolerant of any imperfections in the calculations and predictions of lens power. They are overall a safer, more user-friendly lens, and in the vast majority of patients, that would be my starting point in the first eye. Assuming we have great success in the first eye and patient is keen for surgery on the second eye, we then have a choice. If the patient is not noticing any significant side effects from the multifocal lens, the extended depth of focus lens, and is keen to have that extra little bit of help for near, we may consider a stronger multifocal lens. In the majority of my patients are quite happy actually with the intermediate depth, and if we put two intermediate focus lenses in, distance and intermediate, the images summate and get to about here. For the vast majority of people, that's good enough without having to go on to the stronger multifocal lenses. Just occasionally, patients do complain of side effects such as glare and halo off the multifocal lens. And if they are having problems in the first eye, we can either change the lens, although that's very rare. Usually what we can do is put in a monofocal lens on the other eye. We enhance the quality of the distance vision, avoiding any additional side effects. And the benefit from the extended depth of focus lens in the first eye is usually sufficient to give a blended range of vision, distance, intermediate, and most patients are very happy.